Good morning or afternoon, everyone, and thank you for joining us for our session today. My name is Kristen Reed, and I am a research coordinator with Health Evidence. It is my pleasure today to welcome you to our monthly webinar series. Today we will be discussing behavior change techniques targeting diet and physical activity in type 2 diabetes. Our presenter today is Kevin Cradock, a PhD student at the National University of Ireland. We would like to wish a warm welcome to all of our Health Evidence users that have joined us for this webinar today. So throughout the session today, we will be posting polling questions through the WebEx platform. Your participation in polling questions is voluntary and anonymous, so we hope to enable engagement and stimulate discussion throughout this session. So I will just leave the consent slide up for a moment to give you a chance to read it over and then move on shortly. So just to let everyone know that after today, the PowerPoint presentation and the audio recording will be made available on Health Evidence's YouTube and SlideShare accounts, usually within the next week or so. The links to both of these resources will be posted in the chat section now. So today we are very excited to be talking about the review behavior change techniques targeting both diet and physical activity in type 2 diabetes, a systematic review and meta-analysis. The link to the Health Evidence review page for this systematic review will be posted in the chat section. You can click on the link and follow along in the review using the article full text or PubMed link out, and we will also post the direct link to the full text article and supplementary material. So just a few housekeeping items before we begin. Please use the chat section in WebEx to post your questions or comments. We ask that you send your questions or comments to all participants and not just to the host. Also, please feel free to post your questions and comments throughout the session. Towards the end of the session, we will save some time for the presenter to respond to any questions or comments you might have. For the best connection, we recommend you use a wired internet connection versus wireless. And should you have any connection issues throughout the webinar, we've posted the 24/7 WebEx helpline on this slide as well as in the chat section. So for your audio today, please listen through your speakers. If you are having trouble hearing, you can go to Communicate at the top bar in WebEx and then click Audio Broadcast. So we have our first polling question of the day, which can be found on the right-hand side of the WebEx platform. And really, we're just wondering how many people are joining us today. So if it's just yourself, if there's 2 or 3 in the room with you, 4 to 5, 6 or 10, or over 10. So please just make sure to press submit at the bottom of the poll after you have selected your response. So we're seeing a lot of people joining on their own today, as well as some in groups of 2 or 3 and 4 to 5. So that's really great. So we'll move on. So we'd also like to give a special thanks to our Health Evidence team who've worked to bring this session to you today. There is a large team of us who work to keep Health Evidence current and maintained, as well as coordinate our monthly webinar series. For those of you who may not be familiar, Health Evidence is a service and research organization involved in knowledge translation for public health professionals that was launched in 2005. Our main product is a comprehensive registry of reviews where we provide over 5,000 quality-rated systematic reviews evaluating the effectiveness of public health and health promotion interventions. The main goals of Health Evidence are to make evidence relevant to public health more accessible and make it easier for professionals to use evidence in decision-making. So really the value add for using Health Evidence is that we save you time. We have done the work to screen and appraise each review within our registry. We screen all reviews for relevance to public health and keep our repository up to date by constantly screening relevant databases. At any given time, we are no more than 1 to 2 months behind the publication date. we have done the work for you by critically appraising all reviews through a transparent process whereby you can actually click on the full quality assessment for each review and see our rating for each of our 10 assessment criteria. The Health Evidence website also has various tools and supports for EIDM available online, and many users have informed us that our tools and repository are both easy and simple to use. So I'm just going to quickly touch on the model for evidence-informed decision-making, which we can hopefully keep in mind as the presenter goes through the systematic review with us today. This model consists of 5 components that you can see in the diagram. Traditionally, public health practitioners and decision-makers consider evidence about community health issues in local context, existing resources, and community and political climate in making decisions about programs and policies. However, it's become apparent that considering evidence about research can be challenging to integrate into public health practice. As such, the Health Evidence webinar series is designed to highlight research evidence relevant to public health decisions. So on this next slide, we can see the stages of evidence-informed public health that illustrates the steps involved in evidence-informed practice. The wheel is a guide for practitioners and decision-makers to determine how to address a particular issue by systematically incorporating research evidence into the decision-making process. There are 7 steps outlined here, and today we will focus on how the presenter has worked through the first 4 of these steps in order to help public health decision-makers with the remainder of the steps in this process. So we have our second polling question for the day, and we are wondering how many participants here today have heard or are familiar with PICO F. So there are several people who have heard of the PICOs before, and quite a number who have not as well. So for those of you who aren't familiar, PICO F is a way for you to structure your research questions. It involves defining who the population is that you're interested in and what the intervention, program, or service is that you want to know about, the comparison group, if there is any, and outlining the specific outcomes that you're looking for. Sometimes we also have a particular setting in mind, which we can also state here, for example, school or community settings. The value of a PICO question is that when you have an issue that arises, you can use PICO to turn this into a searchable question, which allows you to further articulate specific components of the question and can then help you to search for relevant information related to your PICO more easily and efficiently. So moving on to our next polling question. We would like to know how often do you use systematic reviews to help inform a program or service in your work? So whether that's always, often, sometimes, or never, or maybe you might not be familiar with what a systematic review is. So I think we're seeing a lot of responses of sometimes, and some often and always as well. So that's great. So moving on, I would like to introduce our presenter for today. We're really excited to have Kevin Cradock, a PhD student at the University of Ireland, joining us from Galway today to present this systematic review. So without further ado, I will pass it along to Kevin. Kevin, thank you very much for joining us today.
Thank you very much, Kristen. So thank you very much, Kristen and Ruan and the Health Evidence team at McMaster for the opportunity to present our systematic review on this forum. So today I'm going to be talking about our systematic review and meta-analysis entitled Behavior Change Techniques Targeting Both Diet and Physical Activity in Type 2 Diabetes, recently published in the International Journal of Behavioral Nutrition and Physical Activity. So just to start, I just must mention some of my affiliations and collaborators. So I'm based in the National University of Galway in Ireland, and I'm linked to the Human Movement Laboratory, and these are some of our collaborators and affiliators also. So just to name my team, I'm part of a team of people working on this systematic review. So that's myself, first of all, and Professor Garrod OLaighin, Professor Francis Finucane, Professor Kathleen Martin Ginis, formerly of McMaster University, now at University of British Columbia, and Assistant Professor Heather Gainforth, also at University of British Columbia, and Dr. Leo Quinlan here in NUI Galway as well. So my main funding source, as Kristen pointed out, I'm a PhD student and I'm funded by the Irish Research Council here in Ireland. So today we're going to chat just briefly a little bit of background information about the review, discuss our research methods and to look at our results and the types of conclusions then we've drawn from that and potentially some future directions, and hopefully we'll have lots of questions and answers with yourself. Okay, so some background just to set the tone and the scene initially. So changing behaviour is one of the cornerstones of type 2 diabetes treatment, particularly changing diet and physical activity behaviour. However, we know that changing any behaviour, particularly diet and physical activity, is challenging. So we know in Ireland and worldwide that the type 2 diabetes is one of the fastest growing and largest health burdens. In 2015, there were 415 million people with type 2 diabetes worldwide. 91% of them had type 2 diabetes, and figures are expected to rise to 642 million by the year 2040. This actually easily surpasses earlier predictions made back in 2004 that by the year 2030 we would have 366 million people. So the rate of type 2 diabetes is growing at a rapid rate. We also know from a global analysis of mortality reported in 1990, where 1.3 million deaths worldwide were due to type 2 diabetes, in 2010, more than twice as many as in 1990. So for diagnosis purposes, we've used the American Diabetes Association criteria of HbA1c, which is one of the three type 2 diabetes criteria outlined by the American Diabetes Association. A HbA1c level of greater than or equal to 6.5% is classified as having type 2 diabetes. The other two are fasting plasma glucose of greater than 126 milligrams per deciliter. And the remaining one is a 2-hour plasma glucose value following a 75-gram oral glucose tolerance test of greater than 200 milligrams per deciliter, or 11 millimoles per litre. Okay, so for our perspective, as I said, we looked at HbA1c. So previously, HbA1c reduction has been classified of 0.5%, 6 millimoles per molecule, has been classified as clinically significant. Other authors have also suggested that 0.3% or 0.33% is also clinically significant. So for our study, we've used the lower value of 0.33% as clinically significant. So the objectives of our study. So our main objective was to try and draw out the features of interventions that were associated with success. So we tried to identify BCTs, which are behaviour change techniques, and features of interventions that were associated with reductions in HbA1c. That was our primary objective. Our secondary objective was to identify the frequency of use of behaviour change techniques in included studies, so how frequently people were actually using these specific techniques. And the third objective was to describe the changes in HbA1c and body weight at different time points. So see, was there any specific trend over different time points. So in terms of our methods, We used a very, very strict inclusion criteria to identify studies for this review. So we used randomized controlled trials exclusively of any duration with a dietary and physical activity intervention. They had to be published studies between 1975 and 2015. These randomized controlled trials also had to have a comparison arm or a control group that would constitute usual care. We looked at adults only, so human participants over 18 years of age with clinically confirmed type 2 diabetes at the time of recruitment. And our principal outcome measure was HbA1c, although we did include studies that reported HbA1c as a secondary outcome. So our exclusion criteria, we excluded studies of type 2 diabetes prevention, or RCTs, of those at risk of type 2 diabetes. We also excluded studies that used exclusively pharmacological agents to treat type 2 diabetes, and RCTs that targeted multiple chronic diseases such as gestational diabetes or type 1 diabetes. This is a key exclusion criteria here, point 4, that we also excluded additional interventions beyond diet and physical activity, or focused on additional behaviours other than diet and physical activity. I'll talk a little bit more on that in a second. We also excluded studies not reported in English and studies not reporting HbA1c as an outcome measure. So if we look at our flow chart, our PRISMA flow chart, I hope you can see that clearly there. And we look at, so we see that we have identified 13 studies from a potential pool of 2015 studies initially. If we look closely at the column on the right-hand side at the bottom where we look at full text articles excluded, we excluded 92 studies where multiple behaviours. So this basically means where studies focused on diet and physical activity and additional behaviour changes. So they looked at additionally things like self-monitoring of blood glucose, smoking cessation, stress reduction. So associated behaviours with diet and physical activity we excluded. So our rationale for excluding this large pool of studies was that we wanted to try and as accurately as possible try and answer our research question, which was looking at purely diet and physical activity interventions. We didn't want to have any interference of the associated behaviours with that. So a little bit more specifically in terms of our methods, we'll just chat briefly on the BCT coding or behaviour change technique coding methodology, how we looked at intervention features, our risk of bias and fidelity assessment. So for our behaviour change technique coding, we used Michi et al. 2013 taxonomy, which was used to identify all the BCTs reported in each study. We separately coded studies for behaviour change techniques for diet behaviour and for physical activity behaviour, and then we combined the studies. So Michi's taxonomy, for those of you maybe not familiar with the taxonomy, as one of the most rigorously developed and validated taxonomy, which consists of 93 different behaviour change techniques, which are divided into 16 different categories. So we developed, to help guide our coding practices, we developed a coding rule book and a rubric to try and guide us through the coding process. This is available in the additional file 1.1.3. And all of the studies included were coded independently by 2 authors separately, and a third coder, master coder, arbitrated between any disagreements and supervised the final decision in terms of the coding and also studies to be included. So one useful thing we have added in our supplementary additional files is we've included an Excel file of all the behaviour change techniques coded and associated text. So in terms of intervention features, the rationale for the intervention features included was derived from a series of previous studies. So we looked at other reviews and we looked at what they reported on and what they used in terms of rationale, and we also looked at a theory coding scheme. We looked specifically at intervention features under the headings of mode of delivery, the frequency of delivery, the intervention provider. We looked at the intensity, the number of interventions intervention sessions, and we looked at other variables such as the use of theory, the number of BCTs included, and the baseline HbA1c. So for risk of bias, we used the Cochrane Collaboration Risk of Bias tool, which looks at the risk of bias across several different criteria, specifically looking at low risk, high risk, or unclear risk of bias. And again, this was carried out in duplicate, and our third master coder arbitrated. We used the same process for fidelity assessment. We used Behaviour's criteria to assess treatment fidelity, which looks at treatment fidelity strategies for improving and monitoring provider training. It looks at delivery of treatment, receipt of treatment, and enactment of treatment skills. We also further coded and assessed the included studies for the subcategories of fidelity, which looks at a deeper layer, a sub-layer of fidelity assessment within each of the categories. And we assigned each of the fidelity categories a score of yes, no, or unclear. So in terms of our overall analysis, our higher level analysis looking at the clinical data of HbA1c and body weight, we inputted all this data into a series of different meta-analyses looking at the HbA1c changes over time, the HbA1c changes overall, and we adopted the same process with body weight. For our moderator analysis, which looks a little bit deeper into the actual studies to assess what's in the specific studies, what are the factors or features or techniques within specific studies that might be associated with successful intervention outcomes. So for our analysis, we carried out a moderator analysis of diet and physical activity, behavior change techniques. We looked at the intervention features. We looked at diet behavior change techniques, and we looked at physical activity behavior change techniques. Okay, so moving on to our results. What did we find? We'll chat about our results in terms of the overall results in terms of HbA1c profile over time and at different time points, and then we look at the moderator analysis and the intervention features and our risk of bias and fidelity. Okay, so again, I hope you can all see that in terms of the details. So if you look at the total 95% confidence interval column and look at the profile of HbA1c results, you'll see the figure minus 1.11% HbA1c at 3 months, minus 0.67% change in HbA1c at 6 months. So both of these are clinically significant and statistically significant. And then if we look at the profile at 12 months and 24 months, you see that figure has fallen to minus 0.28% and minus 0.26%. So just to show you a little bit more clearly in graphical form, this is a simple graph profiling the HbA1c changes over time. The red line looks at the control group and the changes in HbA1c over time, and the green line looks at the changes, the cumulative changes in the intervention group over time. So we can clearly see from this graph that there's a significant, clinically significant, statistically significant change in HbA1c both at 3 months and 6 months. However, that effect is diminished over time. So at both 12 months and 24 months, that effect size, or the reduction in HbA1c, has almost returned back to baseline levels. Okay, so this is the overall meta-analysis figure combining all studies and the data point closest to the end of intervention. So the data point immediately after the end of intervention was the data point we used, and we combined this data point from each of the included studies, and our overall figure is minus 0.53%, which is the change in HbA1c as a result of the diet and physical activity intervention. Okay, so I've taken this table directly from the paper we're reporting on, just to show you some of the figures and the outcome data we have. So this is the moderator analysis of HbA1c for diet and physical activity behavior change techniques. So I've highlighted in yellow the 4 behavior change techniques that are clinically associated with clinically significant changes in HbA1c. The other BCTs, if you see the 5th one down in the column there, 8.7, 2.2, graded tasks, also showed a reduction in HbA1c, but this reduction wasn't clinically significant or statistically significant. So I've taken out those BCTs and put them into a table so it's a little bit clearer to see. So if you look at the BCTs and you see these are the BCTs associated with a greater than 0.3% reduction in HbA1c, apart from the bottom one, graded tasks. So instruction on how to perform a behaviour practice rehearsal, action planning, demonstration of the behaviour are all clinically associated with clinically significant reductions in HbA1c. So typically when coding for behaviour change techniques, the 3 BCTs, instruction on how to perform a behaviour, behavioural practice rehearsal, and the BCT demonstration of behaviour are usually coded together when an individual participates in an exercise class. So say for example, an individual attends an exercise class or a cookery class, these 3 BCTs are generally then coded as present. Action planning is a BCT that's usually coded when the frequency, the duration, or the intensity of the exercise or the dietary program is documented. In other words, the intervention reports on the what, the when, the where, the why, and the possibly not the why, but the how much. So it's reporting on the intervention detail. So each of these BCTs, as I mentioned, have been associated with a clinically significant reduction in HbA1c. So the BCT at the bottom of the list there, the graded tasks BCT, is a BCT that's coded when from Mitchell's taxonomy, it says that when you set easy to perform tasks, making them increasingly difficult but achievable until behaviour is performed. So this BCT, while it was not associated with a clinically significant reduction, it was associated with a reduction in HbA1c. Okay, so from this table, again taken directly from the systematic review, you can see the BCTs that have been most frequently used. So in all of the included studies, the BCT, instruction on how to perform a behaviour, is used, also frequently used as action planning, credible source, and so on. Interestingly, from our study, and it has also been shown in an earlier review, that the most frequently used BCTs are not always the most effective. So in our study, I think it was 6 from the 10 most effective BCTs were amongst the most effective. So the further moderator analysis that we looked at was looking at the intervention features that were associated with, again, a clinically significant reduction in HbA1c. So the results of our study show that if the physical activity was supervised, in the studies where this physical activity was supervised, were associated with a 0.572% reduction in HbA1c. Also, if individuals were part of a group, it was also associated with reductions in HbA1c. If the intervention was carried out, if the exercise intervention was delivered by an expert, such as an exercise physiologist, or the exercise and diet intervention were delivered by both an exercise physiologist and a dietitian, this was also associated with a reduction in HbA1c. Interestingly, if the diet and the physical activity intervention were delivered by a physician or a nurse, this was not associated with reductions in HbA1c. So also you can see from that table that interventions with a higher frequency of total contacts and a higher number of total contacts were also associated with greater reductions in HbA1c. So intuitively, this is what you might expect. You would expect that interventions whereby there is more support given and for a longer period of time, that the intervention is more successful. Also, it showed that individuals who had a high starting HbA1c level were also associated with reductions, greater reductions in HbA1c. Okay, so in terms of fidelity, in almost all the included studies, and we've shown this in another recently accepted systematic review, that fidelity was poorly reported in almost all categories and subcategories. So the fidelity is a key component of the intervention in terms of the intervention being carried out as was intended. So if the intervention is not carried out as intended, or if the fidelity isn't assessed carefully, we cannot truly hang our hat on the intervention findings. So from our studies, the risk of bias overall from our assessment was low. So the conclusions we've taken from our systematic review are that combined diet and physical activity interventions achieved clinically significant and statistically significant reductions in HbA1c at the start of the interventions, at 3 months and at 6 months, but these were not sustained at the later time points of 12 and 24 months. We also identified a series of behaviour change techniques, so the instruction on how to perform a behaviour, behavioural practice rehearsal, action planning, and demonstration of the behaviour were all associated with reductions in HbA1c, as were the 9 different intervention features that we outlined. So we feel that these exploratory findings, so we're ranking the results of the moderator analysis as exploratory findings, that they may guide future research into behaviour change techniques such as the aforementioned instruction on how to perform a behaviour, behavioural practice rehearsal, action planning and demonstration of the behaviour, again, which seem to be associated with better outcomes in type 2 diabetic adults in addition to these intervention features. So in terms of future directions, we recommend that a formal assessment of the effectiveness of both individual BCTs and clustered BCTs become a scientific priority. We would also like to see that specific BCTs are highlighted both for the initiation and the maintenance of behaviour change. So most of the studies we look at don't specify if the same BCTs are being used for either initiation of behaviour change or of maintenance. We also don't see that the frequency of use of certain BCTs is reported. Also of interest is the hierarchical ranking of BCTs. So which BCTs are the most effective and for which behaviours? We're also interested in looking at the synergistic effect of certain BCTs. So does one BCT act as a precursor or as a gateway BCT for another BCT? We don't know this, and this requires further investigation. We also suggest that clearly defined and reported behavioural outcome measures are incorporated into diet and physical activity interventions, and that future studies would follow the tidier guidelines. Overall, we feel that there needs to be a greater transparency and description of BCTs used in reported studies. We would recommend that all future studies would report both the protocol that they use to guide their intervention in detail. We also recommend that there should be greater clarity regarding the theoretical constructs and the models used in published studies. This again would make the audit trail of assessing BCTs much easier. So if you have a clear audit trail of the frequency, of the number of times the BCT is used, the theoretical construct aligned to the behavioural outcome, it becomes much, much easier to assess also, again, if the fidelity is reported. So we also suggest that there's a need and a support for implementing a graded approach to gradually increasing the frequency and intensity of intervention content. We observed in our study that the majority of the support, so the intervention contact and the frequency of contact, is at the beginning of the studies. So it's possible that the drop-off in reduction in HbA1c could simply be a function of the intervention support not being there. So we also suggest that interventions should be structured so that key components are delivered by credible experts. So for example, an exercise physiologist delivers the exercise component, and we also suggest that there should be alignment between the BCTs identified and target behaviours following a comprehensive behavioural diagnosis using something like Mitchie's combi analysis. Okay, so just some the references that we have included in the actual paper are, I've just included the main reference here, but all the references we've alluded to in the presentation are all in the actual paper. And my email is there if anyone would like to contact me or has any questions. I've just posted a link as well. I think Kristen and Farron are going to do this, but I've just included it also to the direct study at the International Journal of Behavioural Nutrition and Physical Activity. I've also just put a note that the additional file 1 and 2 are only available at this link, and they're at the very end of the paper. So we had some challenges and some difficulty with the statistical analysis and the coding methodology for this study. So we felt it was very important to be as transparent as possible in terms of our analysis and the coding methodology that we use. So we have included an Excel file of every single BCT that we coded and also the associated piece of text. So the piece of text that we have taken directly from the intervention is also in the Excel file. So you can see what piece of text we've used to code each single BCT for the actual included study. So we think this will be very useful to anybody that's interested in coding practices. Okay, so I'm going to finish there. I'd like to thank you all for taking the time to listen in, and again thanks to both the health evidence team at McMaster and to specifically thank Rowan and Kristen for their guidance in getting me set up and helping me through this process. So I would look forward to hearing any questions any of you might have, and I'm going to pass you back over to Kristen.
Thank you so much, Kevin. That was a really great presentation. It was really interesting to hear about the potential role of BCTs in diet and physical activity interventions as a lifestyle intervention treatment strategy for type 2 diabetes. So we really appreciate you sharing this walkthrough with us. So I will open it up and encourage you to please ask Kevin your questions while he's here. You can submit your questions actually in the chat box. And we would like to ask that you submit them for all participants. So there are a few coming in right now. So I'll read them out and let you know. So our first question today is what reasons could have prevented numbers from being sustained around 12 and 24 months? Were the BCTs inconsistent at those points?
So can you read that question again to me, Kristen?
Yeah, absolutely. So I think the comment is looking for your insights on what reasons could have prevented those numbers of blood glucose levels from being sustained at 12 and 24 months versus at 3 and 6. So I guess maybe your thoughts on whether some of those behavior change techniques were inconsistent at those points?
Okay, very, very good question, obviously, and I think it's the challenge for all of us, basically, is in why that graph recoils back to the almost baseline levels after 6 months and 12 months. So it comes back to our opening statement, in my opinion, that behaviour change is very, very challenging. So I think we need to look at first of all, look quite simply at where the intervention support is. And the intervention support is predominantly at the beginning of the intervention. So most of the included interventions were 3 and 6 months. So when the intervention support is at that 3 and 6 months, behaviour change is more likely. But when the intervention support is taken away, it's less likely to occur. So one, I think there needs to be a behaviour change support and techniques all the way through. That's the first thing I would suggest. And also, I think if you look at the intensity of the approach, the interventions included appear to be very high intensity at the start. So we would recommend that the interventions are a lower intensity, looking for a smaller change at the initial stages and gradually increasing throughout the intervention period.
Oh, that's really interesting. Thank you, Kevin. Another question that we have coming in is, in your inclusion and exclusion criteria, did you exclude studies that included pharmacotherapy for diabetes? And perhaps maybe some of your thoughts on how you chose those criteria?
Yeah, absolutely. Another great question. Thank you. So we looked at, I'm just going to go back and see if I can find our diagram, our flowchart diagram, see how many studies we excluded based on pharmacotherapy. So our main reason for excluding the pharmacotherapy studies was that we felt that our objective was to answer as clearly as possible what were the features and techniques of the included studies. So what's in those studies that we can take and replicate and identify as being successful. So we didn't want to cloud obviously if we included studies with pharmacotherapy, we would have had a larger pool of studies as we would have with multiple behaviours. But we just felt that if we included studies with pharmacotherapy, we were including another variable that we couldn't control. So yes, it would have increased our pool, but in our opinion, it would have clouded the accuracy of how we were going to answer the question.
Oh, that's really interesting. Thank you, Kevin. That's really neat. And I guess it would be quite the result set with including pharmacotherapy. So another question was you made a comment throughout the presentation that sometimes the most effective behavior change techniques are not being used as commonly. So in your opinion, what would those behavior change techniques be that are most effective?
Super question. I'm glad the participant brought that up, and thank you for doing that. In my opinion, in this study, I think it was 46 different BCTs that we identified. So if you think of 46 from 93, there's a huge range of BCTs that are untapped in terms of their potential and potential usefulness. So I suppose the simple answer, in my opinion, the BCTs that I would think, personally, I think, in my opinion, that should or could be included, potentially effective ones, are BCTs looking at commitment. So particularly the ones in the first category of goals and planning. So BCTs like commitment, BCTs such as a behavioural contract, I think it'd be really important to include. And I also think there's a lot of untapped potential in and around the identity BCTs.
That's really interesting. Actually, so another very related question, which I think I'll ask now because it really blends together with what you've been talking about so far, is have you come across the use of motivational interviewing as a behavior change technique, and could this technique kind of satisfy that fidelity criteria? And I might actually lump it in with another question, is did some of those studies that you looked at examine motivation level and stage of change, and would that maybe have had an influence on compliance or adherence?
Okay, so we might break that one down first of all. So yes, we did. We didn't specifically exclude studies that use motivational interviewing, but because we had such a tight inclusion and exclusion criteria, the studies, I think if memory serves me correctly, the studies that we excluded that had used motivational interviewing as part of their intervention protocol also were focusing on multiple behaviours. So we excluded studies that had multiple behaviours. I think from memory that some of those actually were focusing on motivational interviewing. Again, motivational interviewing would not have been an exclusion criteria, and we would have been happy to code that if they had focused exclusively on behaviour change of diet and physical activity, because as you know, there are BCTs embedded in the motivational interviewing. However, for our coding approach, what we would have loved to do, and this comes back to one of the limitations of the studies, would be to have the audio tape or the audio file of the actual motivational interviewing technique and process, because in our opinion we had a group discussion on this, and one of the only BCTs we could definitively say from a motivational interviewing perspective was that social support is there.
Okay, interesting.
I can't remember the third aspect of that question, Ryan, if you want to rephrase it to me.
Oh, absolutely. So the other kind of component there was whether or not you looked at motivation level and or stage of change, and so whether that might have had an impact on compliance.
Great question. We didn't specifically look at stage of change. I think it's definitely an important factor to look at the trans-theoretical model of these different stages of change. We also didn't specifically look at motivation. I think that could be a very important criteria in intervention design going forward, because ours was a systematic review. And again, because the BCTs included were poorly reported and fidelity was so poorly reported, most of the studies have tried to focus on, what's the word I'm looking for, on tightening their inclusion. So they're looking at intervention participants that are likely to be responsive and likely to be to participate. They did not specifically assess or exclude based on motivation. So unfortunately, we couldn't assess it also, and we didn't specifically look at stages of change, although one or two of the studies we looked at did actually include that.
Oh, that's really interesting. That's good to know. So a couple more questions, I think, still coming in, and please continue to ask away.
Okay.
But Kevin, what are your thoughts about why there were significant changes in blood glucose level related to physical activity with the nutritionists and physiotherapists, but not so with doctors?
I think that's a really, really interesting point, to be honest. It comes back for me as in, so it's the BCT credible source that it's coming out there, basically. So if the information is delivered by a credible source, so it's a hypothesis, or it's speculative because we don't know the answer, basically. But it could be that the expertise is so specific. So, for example, the highest level of knowledge is probably, in terms of exercise, is your exercise physiologist. So the highest level of knowledge in dietary practices is probably your dietitian. So it's a little bit like if the physician was to go and give exercise knowledge or to give dietary knowledge, they're not the highest level of knowledge. It would be a little bit like the exercise physiologist delivering medication knowledge to type 2 diabetes patient. So for me, it comes down to the specificity of the expertise, and that exercise knowledge and knowledge of diet is a very, very specific area. So for me, it could be that the physician or the nurse, although they have expertise in specific areas, it's not specifically in the area of exercise and diet.
That's a really interesting differentiation for sure. So I do have one more question for you, and I believe that in your review you mentioned that all but one of the included studies was actually carried out in the clinical setting. Can you comment perhaps on the transferability of these findings to other settings? So for example, I guess in a community center, which I believe was the one that wasn't in a clinical setting.
This is a very good point, and it's one of the challenges of basically type 2 diabetes treatment, in that what our results are basically saying is that interventions where the individual is supervised and they're getting lots of support and continued support over the longer periods of time is the most effective method. So intuitively, that's kind of what you would expect, I think, in that the more support and the more help that you get and the greater the expertise delivering this help and support, the more effective is likely to be the intervention. However, as your participant is asking, the problem is that it's trying to transfer some of this knowledge and information, and the cost of delivering this information and running this type of treatment program is prohibitive, to be honest. So what we're looking at is trying to identify potentially scalable solutions where this diet and exercise information could be distilled and possibly disseminated in a more effective form that could basically be scalable to a larger population. So that's what we're currently looking at. We're currently looking at exercise and diet interventions through different mediums and how they could be potentially made scalable to larger populations. But you're right, and that's a great point, that there is issues with transferring this information on a scalable approach.
Oh, that's very interesting. I think we'll look forward to hearing more about that research as you go forward. So I will perhaps just start to move on. If there are any additional questions, please don't hesitate to ask, and we'll try to get to them if we have some time at the end. But I would like, no problem. I would like to perhaps open up one of our final polling questions and ask that. Whether or not, I guess, from this webinar, that the information that was presented to you today was helpful, and we have several responses. So strongly agree, agree, neutral, disagree, and strongly disagree. So another just a quick reminder that please actually press submit once you've selected your answers. So we have a lot of individuals that agree and strongly agree. So thank you very much, and thank you, Kevin, for presenting this information to us today. So at this point in the presentation, we'd like to share a few options with you for ways that you can interact with health evidence moving forward. So these include things like visiting our website, registering to receive our monthly tailored registry updates that come out on the 1st of every month, and the monthly newsletter to stay up to date on any new research and upcoming events. Tell your colleagues about healthevidence.org. Follow us on Twitter using the @healthevidence handle. And we encourage your organization to use health evidence to search for review-level evidence to inform program planning and policy decisions, and/or contact us to suggest future topics for webinars and provide feedback on the series. So with these potential actions in mind, we would like to get your thoughts on what are your next steps after learning about this review-level research on behavior change techniques in diet and physical activity interventions for type 2 diabetes. So do you plan to access the full text review, access the quality assessment of the review, consider using the evidence, or tell a colleague about the evidence? And this is a check all that apply response, so you're not limited to one. So I think with the responses we have coming in, there is quite a variety, and I think people will be pursuing all of these action items. So I'm just going to do a quick check to see if there are any questions, and I think there are a few, and we've got a couple minutes. There is one question from our participant, Kevin, that have you considered the National Diabetes Prevention Program?
So I just see that question there. So we haven't, so our systematic review looked exclusively at type 2 diabetes treatment. So the reason we looked at treatment was because the HbA1c, it's very clearly classified in terms of the cutoff points from HbA1c in terms of blood glucose and in terms of analysis. However, we obviously are very interested in the prevention of type 2 diabetes, and we're currently looking at type 2 a diet and physical activity lifestyle program in Ireland that's being run at the CREED program in Ireland in Galway at the moment. So we're looking at that, and we're also obviously interested in the in any other diabetes prevention programs and diabetes treatments programs, particularly from an exercise and diet perspective. Absolutely.
Yes, thank you for your comments. That brings us to the end of the question period, and just about the end of our time. So I would like to give a very big thank you, Kevin, as well to yourself, as well as to our audience today, for posting questions and making this a very engaging and stimulating session. One final reminder that a copy of the recording and PowerPoint presentation of this webinar will be posted online in the next week or so. So thank you to all. And Kevin, I don't know if you have any final words that you'd like to share?
Thank you very much, Kristen, to yourself and Rowan. Thank you for the opportunity, and I hope participants found that useful. We very welcome any feedback, positive or otherwise, that anybody might have. But thank you again for the opportunity, and that's it, I think, yeah.
Wonderful. Well, thank you very much, and then good afternoon, and thank you everyone for joining us today.